All right, hello everybody coming online. Welcome to the Drug and Alcohol Research and Innovation Active Learning Network, Daria. We will jump to our speakers in a moment. It's only just gone 2:30, so and I can see the participant number is rising and rising, so we'll until we've maxed out on that. We'll just wait for that to max out, and then we'll get into today's talk on cannabinoid hyperemesis, and I'll introduce today's. We've got two people speaking, which is a treat. So we'll just, as I say, give people a moment. It's only just gone 2:32, and we're still increasing, which is great to see. All right. Well, that I think might be where we're at for the moment. So again, thanks everybody for coming today to the Drug and Alcohol Research and Innovation Active Learning Network. We're fortunate enough to be joined by two speakers. Firstly, we have Dr. Nic. Now, hang on. I even wrote it down. Ionmhain, Dr. Nic Ionmhain. Yes, I can hear. Apologies to the entire Irish community for that botch attempt. Who is an ED emergency physician based at Liverpool Hospital, down obviously in southwest Sydney. She's a member of the Liverpool Hospital Toxicology Service and is a current New South Wales Poison Information Centre fellow with areas of interest including resus care, particularly in tox and the use of cognitive aids in the resuscitation environment in rare critical illness. She's also joined by Dr. J. Ramanathan. For those of you who haven't met Dr. J, he is the jack of all trades. He is a general physician. He is a geriatrician. He's a clinical pharmacologist. He's everything. And he works predominantly out at Liverpool, but also does some work in the metabolic clinic over at RPA as well, and is just a wonderful resource to every service he engages with. And perhaps you're obviously unlucky to ever have to need a doctor, but very fortunate if you get Jay, because he's very incredibly thorough. So today they're going to be talking about cannabinoid hyperemesis, which I believe was a topic that these guys sort of helped develop some guidelines on down in southwest Sydney, and is something of relevance to our clientele as well. So thanks very much. I think Una's gonna take the reins from here.
So it's actually Jay who's going to start out.
Oh, Jay's going to stay. I'm sorry.
That's all right. And you did fine with my search.
I did my best. I'll go and hide myself in shame now.
Thank you very much, Chris. Thank you for that wonderful introduction, and thank you for the opportunity. First and foremost, the credit goes to Una for putting together this presentation, and she has let me use some of her slides. So for how this whole thing came about is we started seeing some cases of cannabinoid hyperemesis at Liverpool, and we wondered what is the best way forward, and we thought we'll put together some guidelines, which then has translated into a very useful one, and we thought we'd use this opportunity to talk about some of our experience. So the first disclaimer that I'd like to, sorry, it's not, oops, the slide is not progressing. Sorry, for some reason it's frozen. Chris, any thoughts? Seems to have frozen.
Do you want to switch over and I can share my screen? Would that be better?
Yep, sure.
So if you stop sharing.
Okay, I'll stop sharing.
Sorry, everybody, just give us 1 minute.
Sorry, for some
reason. You're fine. You're fine. We were too busy talking before everybody got online and didn't remember to actually flick to the next slide.
I'm just going to change my display settings. All right, let's just check. Yep, Jay, you ready?
Off you go.
So the first disclaimer, I'm not an addiction specialist. I'm only a clinical pharmacologist. So any addiction type questions, I'm going to rely on Chris to help me out. So first and foremost, we start off with a case in keeping with tradition. So ours is that of a 25-year-old male who walks into ED with abdominal pain, nausea, and vomiting. He's frequently requesting hot showers, so much so that we're not even able to get to examine him. He's holding a sick bag with normal-looking vomiters. From an OBS perspective, he's alert, he's afebrile, slightly tachycardic, normal glycemic, and systems exam is mostly blank, except for a dry mucosa and a soft and non-tender abdomen. So would any of you like to think of some differentials for this case? Of course, if it's a 25-year-old female, the first thing you're going to be thinking of is pregnancy. But for a 25-year-old male, would you like to throw some differentials, please?
Well, Jay, I'm sorry to say we only I have the power to speak.
Okay.
Others have the power to write in, but I'll say sepsis.
Excellent. Sepsis. And in keeping with today's theme, let's think about cyclical vomiting or cannabinoid hyperemesis syndrome. So what is cannabinoid hyperemesis syndrome? It was first described in 2004, and often the descriptors used were people presenting with paroxysms of nausea, vomiting, and abdominal pain, lasting for several hours, a compulsive need to have hot showers. And as you all know, toxicology data is a bit like parachute evidence, mostly case series and small case reports, but there were no prospective trials or RCTs at that stage. Next slide, Una. But as you can see in the literature here, and Una has done a nice PubMed search, you can see the numbers slowly creeping up. Now, is this because of increased availability of cannabis? Is this because of decriminalization? It's unclear. And Una will go more into details about this. So in terms of diagnostic criteria, the Mayo Clinic has set forth a nice list of items to look out for. And some of the common things that come up are, is there a history of regular cannabis use at least for a year? Is that pattern of use at least on a weekly basis? And does the person have severe nausea, vomiting, and abdominal pain? Are the symptoms relieved by hot showers? And the age group commonly described there is less than 50, and the vast majority report daily cannabis use. And apparently some features of this was discussed at TAPNA. I wasn't there, but Una will go more into depth about it. The next slide, Una. Now, this is a study, it's a Victorian study where they looked at a 6-year period of the cases presenting to their hospital. And clearly, they've come up with a mnemonic there, the Chanda mnemonic. And it's a study worth looking at. And again, as I said earlier, there aren't very many RCTs, but this was a well enough local study which goes into the details about the hyperemesis and the most common features observed in that setting and what are some of the ways of managing it. Next slide, Una. Now, nobody knows the exact pathophysiology. Perhaps Chris or Brigitte, if they're in the audience, can shed some light. Often it's thought to be a downregulation of the CB1 receptors, the endocannabinoid receptors, either in the chemotherapeutic, the vomiting zone, or it could be an overstimulation of the gut CB1 and CB2 receptors. The exact mechanism is not known. And some thought cannabis being a lipophilic drug, particularly if there is an accumulation of the cerebral fat, there will be certain periods where the fat gets destroyed and the cannabis gets released, termed as a reintoxication effect. Now, these are all hypothetical, but no sort of proven mechanism as such. Next slide, Una. Now, the Rome criteria is that which clearly describes cannabinoid hyperemesis syndrome as a subset of the cyclical vomiting syndrome. And the criteria that they've included there are the stereotypic vomiting occurring at least a week apart and persisting for less than a week, and at least 2 acute episodes in a prior 6-month period. And there's a nice article that is worth reviewing, but this is a useful criteria to keep in mind when you're dealing with CHS. Next one, Una. Now, why does it matter? Why are we even talking about it today? Clearly, the patient factors are significant. Some of these patients do come in droves. They repeatedly present to ED. It is distressing for them. It is distressing for the ED staff, and particularly if you're bed blocked in ED, these patients could take up a significant amount of time and resources. And the length of stay, one of the study where they compared treatment with droperidol without droperidol, was almost half the length of stay. So if you gave the patient droperidol, the length of stay was around about 6 to 7 hours, and without droperidol, as you can see there, almost 14 hours. So they're taking up your ED bed space. You're then looking at, where do I admit this person? Do they go under toxicology or gen med, or do I keep them in the short stay unit? And there could be significant disruptions to the department as such, particularly if you're running every 5 minutes to have a hot shower. From a societal factor, as I said earlier, there's a Victorian study and the US study, which looked at about 43 patients in a year and how it impacts on their workforce. And also, how do we manage these repeat presentations? Should there be a clear sort of flow chart or an admission pathway? And Una will again go into detail about it. And I'll hand you over to Una. Thank you.
Okay. So wearing my hat as an emergency physician, I've been seeing these cases since I started my ED training as a resident in WA. And the first time I learned about it, my consultant picked it up straight away because the patient was having compulsive hot showers in the department, and that was in around 2010 or so. From an ED perspective, these cases can be quite disruptive, and it's not just because of kind of interpersonal issues or anything like that. It's, you know, the fact that they're racing to the bathroom continually for showers because they're getting genuine relief. They're difficult to review. Their symptoms are difficult to abate. They tend to be reasonably well known to the department and actually get quite heavily labelled, and therefore get biases in terms of their treatment, which I don't need to tell drug and alcohol specialists about, is a high risk thing that can happen very easily. They are resource intensive. They consume a lot of bandwidth from the staff, and those kind of compulsive showering habits cause challenges, and often routine antiemetic therapy that we would use and turn people around with fails to work, and they get prolonged stays in the department. And a lot of this can actually, with some proactive thought, can actually be reduced, provided you do some interventions and empower people to provide some treatments that we know seem to work for these patients. And like Jay said, this is a bit difficult to give you really, really good tangible evidence, and a lot of it's going to be based on experience and retrospective studies. But we've got emerging challenges. So what we are seeing certainly in the US is described increased incidence of these cases. As Jay said, some of it may be due to synthetics, potency, maybe the legality kind of issues that legislation is opening up cannabis availability to patients more and more so. It's now being worryingly described in the pediatric population, and by pediatrics I mean teenagers. And actually, interestingly, there's some case reports in the palliative care population as well. And all of them, as I said, what we need to be is actually kind of proactive in terms of what we do and how we treat. So the first question with these patients, as I said, one of the big risks is biasing, and that they actually have a genuine pathology. And we see a patient who uses cannabis, and people immediately jump on the fact that it could be cannabinoid hyperemesis, which I think is a reasonable thought, but I'd emphasize that it's a diagnosis of exclusion, and we still should be thinking of other causes. So patients, at least in their first few presentations, should be getting hematological investigations. They should be getting biochemistry done, because they can get some significant electrolyte derangement with recurrent vomiting. They can also get significant metabolic derangement, including a metabolic alkalosis from recurrent vomiting. If they've been going for a while, they can end up with nutritional deficiencies, and they're all factors that we need to really, really consider in these patients. Things that we kind of advocate for in RED is full blood picture using EASE, maybe a venous gas, LFTs and a lipase, and obviously if they're of childbearing age, they should have a HCG done as well. I don't routinely do urine drug screens on these patients. They mainly give you, if you ask them in a direct manner, you know, without judgment, you know, about their drug use, they'll usually be reasonably forthcoming. Some people will do it if they think it's merited, but I don't routinely do it. Obviously, if they've got a tender abdomen or a surgical abdomen, you should be considering if they need further imaging before you decide it's cannabinoid hyperemesis. The reason I'm emphasising this is there's already been a case, I think, in Western New South Wales for an Indigenous patient who was known to use cannabis, who had been in the department a few times with vomiting, presented with abdominal pain and vomiting, and he died of an abdominal perforation of a perfiscus. And I think that he had initially been discharged with the assumption that it was cannabinoid hyperemesis again. So like any of our patients, particularly for me as an emergency physician with recurrent attenders who may be, you know, dare I say, slightly disruptive and frustrating to staff, you always have to be very careful of this, that you go in with an open mind every time and treat your patients empathetically and carefully. We've talked a bit about the differentials. So the ones that probably genuinely stand out that I always kind of go through with my junior staff and think through in my head as well, that cause recurrent protracted vomiting would be, you know, pregnancy, gastroenteritis. You'll occasionally miss a DKA or a ketosis from another cause causing nausea and vomiting, so you need to be careful about that. Gastroparesis, biliary disease, pancreatitis. And then the rare stuff that you probably see more in physicians' exams, like cycles of abdominal pain and vomiting, like porphyria, which I probably wouldn't routinely look for in a single episode. And then I guess the other thing to be aware of is intracranial events can cause bouts of significant recurrent vomiting, and benign intracranial hypertension and things should be considered as well. And then obviously you should think about your withdrawal state. So why we created a guideline, well, as Jay alluded to, our former head of department kind of brought it up with me one day and said, oh, I feel like we're admitting a lot of these under Gen Med. And I kind of went, well, I don't think we really should be. I think if we treated them proactively with some supportive care, with some early antiemetics, including the use of droperidol, and allowed them to use some capsaicin cream and a few things like that, then we could put them in short stay and only admit them under Gen Med if they were failing short stay with a more than 24 hours short stay duration. Obviously, we're lucky enough that we do have an ED short stay. Not every hospital does, peripherally, particularly if you move out into the peripheries. So I am aware that our guideline wouldn't be a fit for all hospitals and all services. And we're not isolated in doing this. So it looks like a lot of other places have ended up approaching a similar conclusion that guideline development for these cases is a good idea. And actually the ORCHEM, or the Royal College of Emergency Medicine in the UK, have only just released their own suspected hyperemesis guideline in November 2022. If you read the fine print there, you'll notice that they give haloperidol. That's because droperidol is not available very easily from what I can gather in the UK. And also the BNF constrains them a little bit with the way they can give haloperidol. So they tend to give it intramuscularly. But lots of other centres have essentially come up with a similar proposal. And all of them follow a similar kind of set of principles, which I think is probably the mainstay of our talk. So all of them cover the idea of early antiemetic therapy, but early use of agents that you wouldn't routinely come first to mind as an emergency physician as an antiemetic. So agents like droperidol would be the primary thing, or maybe in some centres you might see people use chlorpromazine or midazolam as alternative agents as well, but that would be less common. The other things that we kind of focused on and those guidelines discussed as well is the use of capsaicin cream. And then another focus, which we often forget, is supportive care in analgesia. And what I mean by supportive care is intravenous fluids, electrolyte replacement, maybe considering thiamine and analgesia. And often the best thing to take away from this as well is that these patients tend to be opioid refractory, and it doesn't seem to help. And there's some argument that with cyclical vomiting that opioids might in fact make it worse, and it's very hard to get good evidence for that, but giving some analgesic modalities is a good idea as well. And I guess the primary thing to empower people to do as well, which again I don't really need to discuss with people who work in drug and alcohol, is actually a discussion around cessation, because patients tend to be quite surprised when you suggest to them that maybe their cannabis use is contributing to their presentation because they believe that it's an antiemetic, and usually it takes several discussions to bring them around to that idea and encouraging them to stop using. So the first thing I thought to talk to you about was antipsychotic agents, because and Chris, we were just chatting before we started talking, and Chris was talking about the fact that the antipsychotic agents are not usually first in your mind as an antiemetic agent unless you work in the area of anesthesia or maybe the emergency department. So we usually think of them as ways for either behavioral control for acute agitation in the ED with droperidol, or we think of them as long-term therapy for an underlying mental health disorder. But they actually do have antiemetic properties as well, because they exert an effect on dopaminergic transmission in chemoreceptor trigger zone. And they're actually quite effective at doing that. And the reason behind that's not entirely clear. So it's some of it's anti-dopaminergic. Some of it, I think, is genuinely that it sedates them a little bit, because the vomiting becomes quite, well, it's named cyclical vomiting for a reason, but it becomes quite self-perpetuating, and they get exhausted as well. So sometimes actually giving a little bit of sedation breaks the cycle, in my experience. And if you actually go back to a lot of the anesthetic literature, they very frequently, for refractory postoperative nausea and vomiting, would give antipsychotic agents and midazolam as part of their treatment protocols. In terms of kind of options, Cochrane Review for anesthesia certainly would support the use of antipsychotic agents and phenothiazine and butyrophenone agents in refractory nausea and vomiting. And that's kind of become extrapolated into care for this clinical condition as well. As I said, there's been benzos used in case reports, and certainly when I was doing my anesthetic time, we would give droperidol during the case and for postoperative nausea and vomiting, but we'd also sometimes give midazolam, and I might sometimes do that in ED, but I am appreciating that not everybody is very familiar with giving titrated doses of midazolam. Since we started doing this, some studies have come out, so I'll just show you a bit about that. But I think one of our biggest challenges was empowering people to give the antipsychotics early, giving them an appropriate dosing, allaying concerns about their excessive sedation effects, their worry about extrapyramidal side effects, and probably less so for the emergency physicians, but people maybe with physician background training or people who've been around for a while might remember that there was a black box labeling on droperidol at one point, and they were worried about QT prolongation, which actually from studies in ED with higher dose droperidol for behavioral agitation, it's shown that it doesn't particularly prolong the QT. So in May 2021, which kind of supported our guideline development, a randomized control trial was published in America where they looked at haloperidol, which is the agent that they had access to, comparing haloperidol to ondansetron, and haloperidol was given in 2 separate dosages. It was given in higher dosages and slightly lower dosages as well. And the bottom line was it favored the use of lower dose haloperidol above ondansetron for the abeyance of symptoms and reduced length of stay. And they found haloperidol was more efficacious than ondansetron in terms of those factors. But they found for higher doses of haloperidol, they saw an increased incidence of extrapyramidal side effects. And the doses that they gave were either 0.05 milligrams per kilo or 0.1 milligrams per kilo. So they came down in favor of 0.05. Now you can see that they enrolled 33 subjects. So it's a very, very small trial. So as I recall from the trial, they didn't actually manage to reach their target numbers. So, you know, there's going to be obviously significant flaws in the trial, and there's a desire to kind of create a broader trial and an Australian trial that I'll talk about in a minute. Australian context, so the group in Victoria who've probably published the most on this from an ED perspective are the Victorian Tox group, including Sean Green and Anselm Wong. And they did a retrospective study of their cannabinoid hyperemesis patients, and they found that there was a reduced length of stay in those that were given droperidol at very small doses. So they were giving 6.25 milligrams intravenously to patients, and they felt that that was reducing their length of stay and symptomatology and use of other antiemetics. There's some case reports of other agents being used, including the use of olanzapine and benzodiazepines, but they're probably not as routine, and it's not something that I would routinely give unless there was either a significant contraindication to the use of antipsychotics for benzos, or I felt things were a bit refractory, or there was another reason to give it. Capsaicin is a very interesting one, and I often joke that it's how to save water and not flood your emergency department, and maybe to give patients access to the toilet, because in my experience, the cannabinoid hyperemesis patients are running in and running out, and there's other people who are desperate to use very limited toilet facilities in the ED. So for those that don't know, capsaicin cream is an alkaloid extract from capsaicin, and it's responsible for the hot taste of chili pepper, and you can get it in a cream format. You can buy it actually easily over the counter in the chemist, and there's an argument later on, if these patients go home and they're getting some relief with it, they can actually buy it themselves and self-treat at home. And you basically use it as an analgesic, and usually when my junior doctors ask me what to do or what to tell the patient to do, I kind of use the analogy of using something like Deep Heat or Vicks Vapor Rub or something like that, where you basically put a fingertip size amount on your finger, and then you rub it on the torso, particularly on the abdominal area. You just need to tell them just to be really careful. If you're putting it on the patient, make sure you wear gloves. If the patient's putting it on, ideally they wear gloves and they wash their hands afterwards, because it has undesirable effects if it goes near a mucous membrane, and the patient will never want to use it again, I can imagine. The mechanism is thought to provide the same relief as the hot showers, and the mechanism is not completely clear, but it seems to be something related to the endocannabinoid system, where it has some effects on the TV or P1 receptors, which interact with the endocannabinoid system. And there's some theories that it diverts blood flow and causes these other effects. So as I said, it mimics that hot shower sensation. It can redirect blood flow to the abdominal skin from the enteric system. And there's some thoughts that with this transient receptor potential vanilloid cyst subtype, that it reduces substance P. But there's a lot of papers on the theoretical, which I think are quite complicated, and I don't think I'd again need to really discuss the complexity of cannabinoid systems with drug and alcohol specialists, because I don't know if Brigine's there. She could probably give a treatise on it beyond what I can do. As I said, we've talked about how we do it. I just thought it'd be an interesting fact to tell you that I'm aware of a hospital in Victoria that capsaicin cream is rather expensive, and they came up with an alternative solution where they put Tabasco on patients' abdominal walls, and they would wrap them in Glad wrap. And once they felt the sensation of burning to the skin from the Tabasco, they would take that off and put mayonnaise on it. And anecdotally, they say that made the patient feel better. I mean, it sounds like a recipe for some kind of sandwich, but it's interesting that it worked as an alternative mechanism. We talked about how to put it on, and in RED we stock a 0.03% solution, and we just leave it by the patient's bedside and let them put it on. But as I said, with those kind of caveats, just to be careful, because I don't really want a screaming patient who's put it on a mucous membrane in the department. The evidence, so there's multiple studies now. All of them are probably inadequate in terms of their powering, because as I said, it's difficult to get the numbers to get clear and obvious evidence for a lot of things in toxicology. It certainly seems to be reducing the amount of antiemetics that people need. It certainly seems to be reducing their abdominal pain symptomatology. Some studies are conflicting about length of stay and duration. There's not much discussion about harm, except for that issue that if people just put it in the wrong place. The thing that they did comment on in the studies is it actually maybe empowers patients to think about it as something they can do at home if they get some symptom relief from it, and actually to have it. And it does seem to make, from talking to people, emergency department life for both the patient and staff alike, and other patients a lot easier. There's some argument that it might reduce length of stay if you get in front of the game or in front of the tine and give it early on. And it's a watch this space again that ideally we'll get some more studies, and you can see there's some more studies there, and there's one attempt at a meta-analysis where they said that there was a resolution of symptoms that was a little bit sooner and reduced length of stay, but they acknowledged that it's challenging to study at the moment. So obviously we need a larger RCT, so there's been one attempt there, and these slides will be circulated so you can use them as your reference points if you want to look at some abstract. And lastly, I guess the thing to cover is analgesia. So opioid avoidance is kind of encouraged because they don't seem to respond to it, and it just clouds the picture a little bit, and patients then come in, looking agitated and distressed and want opioids because their perceived effect is that they'll get some relief from that. There's some suggestion that drugs like ketorolac might help, particularly for cyclical vomiting syndrome, and that seems to be affecting a reduction in prostaglandin E2. And there's not much actually published on it. It's very anecdotal. The dosage seems to be unclear, but generally speaking, it would follow what we would do in ED practice anyway, which is kind of 10 milligrams IM now that we know that that's reasonably effective, instead of 30. So we know that there's a more effective ceiling dose, but it's not routinely available in a lot of EDs. There's been some adverse instances with ketorolac being given to inappropriate patients, like patients with renal failure or above a certain age. So it's not something that I would routinely encourage, but I do occasionally use it if pain is a big factor, and people seem to have gotten a bit better with it. Last thing that I would really emphasize is adjuncts for those complications. So patients are going to feel miserable because they're dehydrated as well. So intravenous fluid replacement should be given. I'm happy with normal saline or Hartmann's. Probably the former intensive care trainee in me prefers Hartmann's than abnormal saline, but really for the amount of fluid that you're giving in these acute patients, sodium chloride is fine. Dextrose supplementation should be considered in those that you particularly think are deficient. If you're concerned that they need dextrose supplementation and they're not hypoglycemic, they probably also need and not ketotic, then you should consider giving them thiamine, Obviously, if they're symptomatic and hypoglycemic, you should be looking for other causes or other issues, but also giving them dextrose if they've got significant symptoms of hypoglycemia. And it's important to correct those electrolyte disorders as well. So if they're hypokalemic, hypomagnesiemic, they're all important to address and correct as well. And then some of them, there's one patient who's come in under us a couple of times who has developed significant kidney injury associated with it as well. So he needs to get his UECs monitored for his renal function as well. And I guess the other thing to be aware of is some of these patients for particularly violent vomiting can get esophageal injury, or they can get malar vice tears and things along that line. So it's just being mindful that these complications can happen as well. Ultimate cure. Cessation, I've said already, this can be really confusing for a patient when you turn around and you say, well, I think this is why this is happening to you. We've seen this a lot more over the last couple of years. We're not really sure why this happens, but this is the only thing that we seem to know that works. In terms of cyclical vomiting syndrome, even though the treatment principles in terms of the antiemetics kind of cross over quite nicely, this can be quite different, and it's worth getting gastroenterology input, because they actually do consider some other medications that they might offer, like tricyclic antidepressants medications. So in conclusion, I guess the point is to just empower some further options in treatment, and that early use of droperidol. And I didn't really allude to the doses that I would use. So I would usually use 0.5 to 1 milligram of droperidol IV. I certainly wouldn't be using the big doses that I would use for sedative and behavioral control purposes. Future plans from a research perspective, Joe Rotella, who did that study in he did it actually in the northern in Victoria, really wants to do a multi-state research study, which first of all is to try and define the characteristics of these patients on a more broad interstate level, and also see if we can see what people are doing in terms of their practice and their length of stay and get a baseline. And then what he wants to do is actually run a study a little bit like that HAVOC study, looking at haloperidol and ondansetron, but actually looking at droperidol. I think it's really important to identify patients and their cohorts as well, and see if we can actually educate and intervene and tell them that this can happen. And then I think we do need to think of the broader implications for public health. So I know in the recent American elections that have just happened, I think another state, I can't remember which state it was it maybe Oregon, were voting about cannabis legislation. So obviously cannabis is becoming more available. We're seeing more synthetics. We're seeing an increase in use, and there are broader implications for public health. And that includes obviously, distress and symptom management for individual patients, burden on healthcare system. But I think we probably need to acknowledge the socioeconomic and societal impact of these things as well. And if you can reduce an ED length of stay, make a patient feel better, turn them around in around 6 hours time, and then decrease their use, I think that's quite important to look at and intervene from an educational perspective. So with that, I'm going to ask if anybody has any questions, and we can circulate our guideline. I'm sure Jay would be very happy if we did that. And we've actually been asked by some members of the CEC, I think, and a few other people are kind of interested in this as well. So it seems to be becoming a bit of a topic around New South Wales in general.
Thanks very much. That was and Jay, that was incredibly thorough. And look, I don't think, other than the work that Joe Rotella, I must say Joe Rotella is my birthday buddy down in Melbourne. Other than him, I don't think anyone's done a more thorough review of all of the literature and everything. So thank you very much for that and all of it. It's nice to have somebody clinical experience on top of that as well. One question I had, we'll jump to questions from the audience in a moment. One question I had was just, sometimes there can be a bit of, do you ever get times when there's a bit of conjecture around use? The patient themselves is saying, look, I don't use much cannabis. And then everybody's saying, oh, we think this is cannabis, hyperemesis, and they're just, and I mean, at that point, it's really up to, I think gastro need to start thinking about cyclical vomiting syndrome at that stage, but maybe your experience.
So I guess from wearing my emergency physician hat, we do get that sometimes, and we do get people with cyclical vomiting. I know there's somebody that I've seen pretty recently who started coming in on a monthly basis, who's a female patient, and I ask her every time and she denies it, and I actually believe her, but you have to ask. And I think it's like everything, you have to ask them in an open way and give them ample opportunity in a non-judgmental fashion. And if they still deny it, I think you have to take them on good faith. There's some people who are using, and they are using, and sometimes it transpires after their third or fourth admission, then they reveal it. But equally, you're not, the way I view it as an emergency physician is I've raised the question, I've advised them about it regardless of what they reveal to me. And then I raise the question if there's another cause. From an emergency department treatment, it doesn't really change what I do. So I treat cyclical vomiting with droperidol as well. And I still treat the patients symptomatically and supportively. I may not just give them the capsaicin cream because I don't find that they're running to the shower as much. But I think, I personally don't run in and do drug screens on them. I think some people will argue you could do it. I think, if the patient wants to reveal that to me, then that's the patient's prerogative. I'll just tell them it can happen, just so they know if they are using, or if they know somebody who's using. And I describe it in the abstract, and then I hope my fellow colleagues will continue to probe that on every admission.
And look, I think you can also.
Just to add to that.
No, sorry, go, Chad. Yeah.
Just to add to what Una said, as the Mayo paper says, there could be months to years before the actual diagnosis is made, because people are not often linking the usage to the actual syndrome. So once you've considered all the differential, I think you'll have to treat it. And often my first go-to drug would be droperidol rather than antiemetics.
No, that's and look, I think even in those guidelines you pointed out, for CVS they lean to droperidol as well, I think, from memory, but you would know better than me.
Yeah.
What was I going to say? There was a question here, look, I think you've kind of covered, which was about where putting the cream on. So, I mean, you just put it on the abdomen.
Abdomen and chest.
Abdomen and chest.
Yes. As I said,
and make sure they've got gloves on. Yeah, sorry.
The easiest way, maybe they don't use it anymore, but as I said, I do describe it a bit like putting deep heat or fixed vapor rub on, if you put it on the upper chest and torso. But as I said, the gloves are a good idea, because you just do not want that to go anywhere else, especially if they're running to the bathroom on a regular basis.
Yeah, absolutely. I mean, you just sort of rub your eye like that, and you're going to be in a world of trouble. So,
or anywhere else where I will never hear the end of it.
Pharmacy will be able to compound it for you. You need to give them some time though, Chris, because sometimes if they're running through tubes and tubes, it's going to take quite a bit of their time, but otherwise pharmacy will compound it for you.
You're making me feel a bit guilty about the one time when I prescribed somebody capsaicin cream for post-hepatic neuralgia. And I didn't advise them to put a glove on, and I hope, and I'm sitting here hoping and praying that poor woman was okay. So a lesson for me for next time. That was very silly of me.
I think it's really important. Like, it seems so daft, but I know somebody who went to bit awry with deep heat cream once as well. And the real thing is actually washing your hands, because people will go back and touch the same area again.
Yep.
So it's advising them as well about touching the same area, because they managed to get deep heat cream near the eye, I think, because they had put it on a leg or something else and then rubbed their eye. So I think that it's even if you put a glove on, if they put their paws back on the same area, they're still at risk of putting it somewhere else.
Yep.
And there is another question about Tiger Balm, Chris, in the chat box.
Yes.
Tiger Balm active ingredients are camphor and menthol. They may not have the same effect as capsaicin, which acts by that hypothetical mechanism of blocking the endocannabinoid, the receptors, I think. Yeah.
I detested Tiger Balm as a child growing up, so I would never have been reaching for it in the first place. Awful stuff. What was I going to say? Looks like we this stage we don't have any other question. I think, because frankly you've covered it all. I think that's really wonderful, and it's something to keep in the back of the mind. For all of the generalists out there, and for those patients that we have that, most of the time we do manage the withdrawal side of things, but sometimes we do get asked about these presentations. And I guess it's up to us to work on something a bit better to help with the long-term abstinence. But there are some, but we have presented on that earlier in the year, so I advise everybody to go and have a look at those presentations as well. So if there's no more questions for now, then I should mention that next week will be me. We've had a few changes late in the year with people being seconded away to various things, and unfortunately one of our speakers has fallen through. So I will jump into the hole that is there, and I will be talking about drug testing in the addiction sphere. So please join us next week for that. But for now, please join me in thanking Dr. Nic Ionmhain and Dr. Ramanathan for their wonderful presentation today. Thanks very much.
Thank you very much, Chris, for the opportunity.
Thanks for having me.
Thank you, Ali.
Thanks.
Thank you.
Bye.
Bye-bye. Thank you, Una. Bye.
See you.
See ya. See you all.